PAH.TV coverage of CHEST 2015. Happy to have back with us Dr. Jean Elwing. She is Associate Professor and Director of the PAH program at the University of Cincinnati. Nice to see you again.
Nice to see you. Thank you for having me back.
So here at your conference, you were involved in a session, and let's talk about some of the elements of that. Let's talk first, what waveforms derived from right heart catheterizations are considered most likely to indicate the presence of PAH?
So actually, Dr. Victor Test did a session on looking at waveforms and really trying your best to interpret them and what the challenges are. And we look at right atrial pressure, and that tells us a lot about the severity of illness, the health of the right ventricle. And then we go on and we look at the right ventricle and the pulmonary artery, and we characterize those waveforms a bit better and how you transition from that to the wedge and how to actually get a good wedge and how to measure a wedge sat to be able to verify you're in the right place. And unless we know that's right and correct and we've measured it at the right place, we may misdiagnose our patients. We talked a lot about making sure we're leveled and zeroed and all the different things that are extremely important for proper diagnosis. So that was a great session.
So a right heart cath can be tricky for someone who's not very experienced to either miss the presence or the absence of PAH.
Absolutely. And even if you're very experienced, these people are quite ill. Sometimes it's very hard to get the right tracings, and you have to have all your staff on board with you to know exactly how sensitive this test is for this patient. It will determine how we manage them for a very long time, and if we get the wrong answers, we will mismanage them and possibly worsen their outcome.
Now, your part of this session was about pulmonary function tests. What did you cover there?
So I covered both what PFTs looked like in the NIH registry, what they looked like in the REVEAL registry, and what we can gain from looking at pulmonary function tests about prognosis. So I'll tell you a bit about that. Okay, in the REVEAL registry, before we had treatment, those patients had mildly decreased total lung capacity and forced vital capacity, so very mild impairments of their pulmonary mechanics. But when you looked at their diffusing capacity, that was a bit lowered, and that's what we also see going forward, even after the era of treatment. So the DLCO was low in those patients and in some of the patients in REVEAL, and we found that was a marker for poor prognosis. If you look at a DLCO in the severely decreased range, that was less than 32% in REVEAL, that was a marker for increased mortality at 1 year in both the all patients enrolled and the newly diagnosed patients. So we can use pulmonary function tests. They're simple tests we use to diagnose patients with either pulmonary hypertension or hypoxic pulmonary hypertension, but we can also use it to risk stratify. So that was important.
So what do those findings say to you?
So that just tells me that the vasculature is more diseased in certain patients, and those patients will have a poorer outcome. But if we can catch those patients earlier, or we can target those patients more aggressively, maybe we can change the outcome. So the other interesting thing in scleroderma patients, when you're following them for the development of pulmonary hypertension, the DLCO is oftentimes declining even a decade before they're diagnosed. So in that subsegment, the scleroderma patients, it may be a marker for the development of PAH. So that was really interesting. So.
Always.
Yeah.
Thank you. Thanks for joining us. Thanks for sharing
thank you.
some time. Appreciate it.